bring the meeting to order. Thank you all for attending. We're one short of a quorum, but I'm optimistic one more person's going to show up. This morning, I'd like to review the minutes. We can't vote on them since we don't have a quorum, but if anyone has any additions, corrections, deletions, or any kind of information they want to apply, please let us know. And once we have a quorum, we can vote on it. Under old business, of course, our protocols are still coming up. Do you want to just, Mike, we'll do protocol committee now?
Sure. So the first item is that in front of you, you should have the advisory on oxygen and pulse oximetry. That's been before this committee before. This is the final policy on it, or advisory on it. So once we get quorum here today, then we'll need to vote that.
Done.
Okay, so.
Yep.
And then
you're the man, Dennis.
No, all the time. All the time.
Just a correction to it. The fourth line down under, in the second paragraph, third line down, second paragraph, you got a double B. Oxygen B must be.
He was very confirmatory.
B must be.
I think that's River.
I think it's been changed.
All right, well, that's what I would.
Okay, no, yeah, that's.
To be or not to be?
So I'll just make sure that they.
This is an old version.
Okay.
Oh, that's the new one.
That's what I was
The
adding.
new one, no, that's, is that the one
I
that's
think that's
outside?
what it is.
Oh, then wait a second, then that is not the proper version.
Okay, can I have the order?
The one drafted, or updated 9/13/19 is the proper one. So that was corrected as a result of those
I'll
typos.
go make them.
Great.
Thanks, Karen.
And Karen, also just make sure then that you have the right one regarding hemostatic dressing. That's 9/13/19 as well. So take that one too. Okay, so we'll come back to that. Also for the agenda purposes, the Regional Stroke Destination Advisory, that really has been tabled indefinitely. We can remove that from future agendas. We're really waiting to see what happens at a state level with regards to hospital stroke designations.
Can I just make a comment on that?
Absolutely.
I don't think we're going to get any. I don't think we're going to get any advisories from the state.
We got one. They talked about Albany.
Oh, really?
Yeah, this is the only, October 17th it came out, making Albany Medical Center a comprehensive stroke center. But that's the only one I've seen.
No. But, yeah, everyone by March of 21, all the hospitals are going to have their thing in place. That's a done deal, okay? So they're going to have to declare themselves one way or the other, whatever their designation is. Comprehensive, so, but we, as EMS, have got to decide about destination. They said they're not going to do this. So we need to start thinking about how we're going to do that. So I wouldn't wait for the state. I mean, at least the vibe I got from all this talk is they're not going to do it for us, and they're not going to lay out. They said it was up to the various regions, and we got to figure this out. So we may want to start putting, our thinking hats on about how we want to do this before everyone gets. Or we can wait until March of 21. But I think that what's going to happen is going to be spontaneous. EMS is going to say, we want to know what to do. We want to know where to go. There's these comprehensive strokes, there's these thrombectomy capable, there's this, where do I take my patient for the best possible result, even before those things come out. So I think we need to think about it.
Have you been on those Mission Lifeline
Yeah.
stroke calls? Because I haven't been on one in a while.
Yeah.
Weren't they picking, or they were going to decide on a tool of choice?
Well, you mean
As far as stroke, I mean,
a pre-hospital, you
Yeah.
mean sort of a stroke tool to use in terms
Yeah.
of determining? Yeah, no, they have not. I've introduced that onto the Mission Lifeline thing, and I'm not hearing, again, it's like, okay, what should we do? I mean, New York is using LAMS, various places, even using a pre-hospital tool. We know, I think, from whatever they've written in the journals, that the Cincinnati tool is excellent for predicting a stroke, but it's not as good for predicting a large vessel occlusion. So if we want to give that to EMS, there's some better pre-hospital tools. So that's one thing we got to pick, and then the other thing we got to do is start talking about destination.
if you have the tool, and you have a tool that's sensitive for LVO, then the destination part's easy because we, setting up a protocol saying you have to go somewhere where they can do an endovascular retrieval if your score is above X, depending on whatever your tool is. So if we can decide on a tool, the rest of it's kind of rote, right? In theory.
Then it becomes a very political thing because
Yeah.
hospitals are going to say, "Hey, man, you're cutting us out,"
Yeah.
That's the
all that
same
kind of
as
stuff.
every-
So it's got to
yeah.
be pretty. We got to
Has
be
to be
pretty
evidence-based.
together on this so
Nevertheless,
that everyone.
that's a
feel-
very rational, evidence-based way
Right.
to approach it. If there's a validated pre-hospital stroke severity tool, then it makes the writing of the protocol less political and
Yeah.
Or this is
No,
what
I
it is.
agree, but everyone's got to feel comfortable about this. I mean, hospitals as well as EMS got to feel comfortable about it so that
I don't know. if
we
people-
don't get a lot of flashback.
Hospitals are not going to feel. I mean, just like STEMI,
Yeah.
they're not going to feel comfortable when they're not doing the procedure.
Just from the RTAC, for everybody's information, they're looking at developing a map to give to EMS that identifies all centers in our region by level of trauma level ability, from 4s right to 1s. Is that something that could be done with the stroke centers?
Easily.
To do that out as a copy of their protocol?
They do the work and do a digital one. It's pretty easy for us to just.
It's just a matter of
Switch
the
designations.
facilities identifying. And I know that we also look at CSTAT or the LA race scale for LVOs.
I think that the concern that we had when we first started looking at this is, since the state is not recognizing the different levels today, how do we then write an advisory that talks about that topic? And I know that Bill was on a conference call with the state executive directors, and that was the concern as well. How do you change and make those determinations when the state doesn't currently recognize those levels? And that's why we've drafted it, we have a flow chart, but the challenge is that it's a self-declared position, and so that's what makes this a real challenge for us, I think.
But they won't be self-declared. And what's the
Right.
Well,
As of-
That's why
yeah.
that's why our recommendation from the
Just to
committee
wait.
was, you know what, we might as well just wait, and then we'll have to wait and see what happens, and then maybe we can be one of the first. We have it written, we've got the flow chart written, we just don't have anybody that's designating, and if you just got a letter.
This is the first one.
That's the first one, that's
Yeah.
the first designation that we've seen then. That's our challenge, is it would be self-declared, and then how do you validate that? Certainly, the regional office is not in a position to validate whether or not, the hospital is capable of one of the
Right.
levels that we identify.
Yeah.
So with the way these come out and what should be happening, is that everyone decides what category they fall into, what they can accommodate, and they are supposed to get this done before the 2020, because after that it'll be under Joint Commission or whoever you use as your governing body to administer surveillance and to look at, do you still follow under those designations? So up until that time, the state will allow people to have the designation, but after that, it'll be coming under one of the federal agencies, whoever you use, DNV, Joint Commissioner, or as the such. So I think what we have written up so far is, utilizing a tool that we will have people, whichever category you fall under, then you'll be you'll be delineated, these are the places that are comprehensive, these are the places that are regional, and et cetera. So we kind of are ready, but we were waiting to see what the exact designations were.
In terms of, right, we operate under these collaborative protocols. Is there anything coming out of the collaborative group? Because in terms of that tool? Because, we would all like to be under the same tool for the ease of the medics. This stuff's complicated enough.
Yeah.
And then to have a different tool in, some of our people in Westchester work in New York City, okay, and then certainly work in the Hudson Valley and the vice versa.
So what I probably could speculate on is if we now have a letter from Albany Med that states that they're going to be a comprehensive, that probably will start at the Remo area and go out from there into the collaborative group. So I think we should just stay right on the shirt tail of them right now. Let's watch how this goes and then just stay right with that. I think that would then flow into the collaborative.
Okay, good, but I think early we should try to pick out that tool.
Yes.
So that we can start
So the
teaching
Remo-
to the
so
tool,
the
or
Remo
everyone
area-
can be on the same thing.
The Remo area does use the FAST, okay, which is the way that
They
ours
do.
is drafted.
Okay.
Okay? And so,
Okay.
in fact, we grabbed ours from them, and that's why we were really trying to stay ahead of it, but without having that designation of comprehensive around here, it's very difficult for us to even implement this because it's not going to mean anything. And so ours is a draft or a copy of the Remo one modified for us.
Can you send it to Eric?
I can, absolutely.
Want to see it, Eric? You can
Sure,
take-
absolutely.
Or even the whole committee
Yeah,
can
yeah.
can take a peek at
Yeah.
it, just what we've been working on so far.
Sure, you want to send
in
that to
protocol.
the entire group here?
Yeah.
Yeah.
Why
Send that
not?
out as a draft, that we have something.
That'd be great.
Yeah.
It's written, it's just,
And-
it's tough to pull the trigger on it.
People can look at it and
Absolutely.
give their feedback.
Okay, so then
We also-
let's not remove that then from the agenda for future meetings. We'll keep it, this was a good discussion, we'll keep it
Yeah.
on.
Cool.
And we'll send it out and we'll see where we need to go from here.
And
So
I
we'll
would
have to
say,
talk
Mike,
about
it's
it.
a matter of the protocol lagging the evidence. So I feel confident at the upcoming NAEMSP meeting in January, we'll have a fair update on, exactly how the evidence base is progressing on the pre-hospital stroke severity scale. So, maybe in just a couple of months after NAEMSP, we'll have a better understanding of the way the literature is shaping up.
Awesome.
We also have an executive director meeting tomorrow morning, so I'll make sure I bring that up to see if they have any more designations and what their plans are.
Perfect. So, continuing with protocol committee, the EMS summit, which we had in February, we have a follow-up meeting scheduled for those people who have expressed an interest in taking on and charging this movement forward. It's going to be here on November 21 at 7 p.m. So we're hoping to really switch that out of protocol committee and into a committee that's dedicated just to address those issues. With regard to the ALS collaborative protocol, the apps for both Android and Apple have been released. If your phone is on automatic update, you will have been already pushed those. If not, you need to go out there and update your phones to grab those updates. The training component that's going along with this is also being done by the collaborative group. We decided instead of doing our own, we were just going to hop with the collaborative group and do that. We really had expected to see that out now. It's going to be on a similar platform to the New York State BLS protocol. We haven't seen it yet. We will, again, follow up, but I would expect here very soon we're going to see that roll out, and that will be the same type of process. There's an online quiz or exam that gets done as a part of it, and that's how we're going to do the update. The regional office has already switched over and is testing on the new protocol for new providers. Let's go back to pulse oximetry and oxygen, and just to make sure that everybody is on the current one, I will read it for the record. Regarding the use of oxygen and pulse oximetry, the New York State BLS for basic life support BLS protocols and the New York State Collaborative Advanced Life Support ALS protocols specify the administration of oxygen based on oxygen saturation levels of the blood. All first response and transporting vehicles capable of administering oxygen must be equipped with a pulse oximeter to properly assess the oxygen saturation and to make an appropriate decision regarding oxygen therapy. Pulse oximetry is a standard of care, assuring our providers are making good clinical decisions with information gathered through good, thorough assessments and real-time data. So, I don't know if you want to vote on that right now while we're
Yeah, because
here?
we have a quorum now.
Could we just discuss it?
Yes.
Absolutely, yeah, sure.
Would it be worthwhile to define like hypoxia, or we'll say like a reference as discussed in the protocol version X, Y, and Z? Hypoxia is defined by having oxygen saturation less than. Is it worthwhile, or is that intentional about that?
So to me, the challenge with that is then you need to keep this document up with the collaborative protocols.
Yeah.
This makes reference to the BLS and ALS collaborative protocol, or both protocols. So therefore, it's that document then that you keep up. All we're saying here is you need to have the equipment to be able to do what the protocols say.
And we have it designated in the protocol.
Perfect. And then would it be worthwhile just to insert, I know that overarchingly, traumatic brain injury and hypoxia can be a bad combination. So we don't want to discourage people who may have like an O2 sat of 93 or 94%, but are significantly head injured. That patient may in fact benefit from oxygen therapy. So how do you think we might incorporate that? Again, because it's so nuanced.
So I will tell you from my experience, and certainly you all have much more experience at this than I, but I can tell you just by listening that continues to be a very highly controversial topic, and both sides just can't even agree on it, and that the jury is still out.
For traumatic brain injury?
For traumatic brain injury. There's the compelling conversations and discussions both ways, certainly again, way above my level. And so I don't know, and I'll certainly defer to Dr. Murphy, who sits on that group for us to help make that, but it's been a hot topic.
Where it's been the hottest is in the trauma advisory committees, both on a regional level and a state level. And it was going back and forth, and they were trying to designate numbers, and then people were having discussions of exactly that. With a TBI, you want to not limit the amount of oxygen. So the collaboratives now are using, a percentage on the pulse oximetry. However, I think all these cases has to go to medical control, and that we are going to encourage people to call and ask for help if they need it, because I think that's where half this problem comes from. But it really was an issue on the STAC and RTAC committees where the discussion came.
Why not just carve it out?
So,
Yeah, like insert a sentence like, please consider good medical decision-making in the use of supplemental oxygen for the subgroup of patients, including traumatic brain injury.
So
Should
there
there be any-
is-
Should there
there
be
is-
any questions or concerns, or request for additional guidance, please reach out to medical control.
I'm pulling up the protocol, and if any of you have it on your phone, go ahead and try to beat me. Well, but I believe that there is a separate sentence in here under considerations.
Right.
So
Down the bottom, I'm pretty sure.
I just remember reading it at one point, and so it may already be in here.
To sort of also go back to what Mike was saying about having a document that references another, if the collaborative protocol gets changed because of that, we don't have to change this one again. It's just easier to say reference that, maybe we need to put some pressure into the collaborative group with it, or even if it ends up being another notice out from the region, maybe that would be better too, so we don't have to keep going back and say, okay, protocol changed, how many documents do we have to go back and change now? Match the protocol.
Yeah, I think if you just reference the collaborative, it's the best. Eric, did you want to say something?
well, yeah, I just came back from Denver, the American College of Emergency Physicians thing, so I went to a couple of these debates. And anyway, at least from what I could sort out from it, again, I think there's the benefit for oxygen is in the severe head trauma patient, okay? So then, but then that's how does EMS determine it? Is it determined by, what about that person who's got the GCS of 14 or 13 or something like that? Or should they get it? Or do you is it really, when we start getting down to 10 or 8 or whatever. So it's sort of a hard thing for EMS to somewhat determine in those early, contact with the patient. And a little bit clearer by the time they get into us. The patient that period of time somewhat the patient declares themselves a little as, significant trauma. And so, anyway, it seems that from what I gathered from the evidence, or what they were all presenting, was that yes, this oxygenation of the brain in severe head trauma is quite important, and what we do in those initial time period is does determine outcome.
Is there any evidence of harm in the trauma patient giving oxygen? I mean, we have this, COPD, we have MI, no, it doesn't help, but does it hurt anybody that's
Yeah,
traumatically
on
injured?
the medical side, there is some
Sure.
evidence of
Yeah.
harm.
Sure.
But on the traumatic side, I thought that trauma and head injury was less controversial. I didn't realize this was controversial. I thght that was kind of like we were trying to teach and advocate for that.
I
I mean,
think
what I'm
it
saying
was
is-
more the pulse oximetry, cut off, where it became an issue, because with a TBI person, you want to provide them with oxygen, because you're not going to have them manifest right away the level of their, injured head, and that you want that oxygen to be on board and the oxygen carrying capacity, and yet it may not declare itself until they arrive and we start yelling at them.
But that's what I'm saying, like, if there's no evidence of harm in the trauma patient to give oxygen, then why not just carve it out and say, regarding, I think this advisory is great because it brings pulse oximetry as a requirement
Standard of
to the
care.
whole, which is enhances care overall. But and in the trauma patient as well, it's just as useful to know that your patient's hypoxic. But if it doesn't hurt to give oxygen to a trauma patient, to the knowledge that we have at this point, why not just advocate for it in lieu of evidence to the contrary?
I think what I would fear is putting out this advisory. Some people may say, well, the O2 sat was 92 and it was a severely head injured patient. So because of this advisory, I decided not to give oxygen.
So the oxygen administration protocol, in key points, the first bullet is oxygen should be titrated to maintain saturation at or just above 94% and or to treat signs of dyspnea. If there is a situation in which the patient may be unstable and hypoxia might be missed, parentheses, such as major trauma, end of parentheses, it is acceptable to place the patient on high flow oxygen. So
That's pretty
there
good.
is some.
Yeah, so that brought in the whole trauma thing. It didn't specify just TBIs, but it was more of a traumatic.
What I'm looking at is from the perspective of our providers, right? So this is like an elite group here, right? So what I want is for the advisory to be helpful, so that not that based on this advisory, they not have to reference 4 protocols to figure out what they're supposed to do in the street. So could we take that paragraph and as a subnote or a footnote insert it into this advisory?
The least common denominator is able to pick it
Yeah.
up and say, oh, but I still need to give oxygen for
And so
trauma
that way you're
patients.
reading this and you're like, okay, well now I'll remember for the trauma patients too, that supplemental oxygen. In other words, we're figuring it out ourselves and we have to reference 3 or 4 things to get to the actual protocol. So, sometimes.
So, and one of the challenges too is, an advisory such as this really talks to agency leads as well, where a paramedic on the street may never even see this advisory. This is to an EMS director that says, you have to put pulse oximetry in all your vehicles. The paramedic should be familiar with what the content of that is. And EMT, right.
We could add just the small part of the paragraph that, talks about, best practice with trauma patients, and not put numbers there so that we don't pigeonhole and have to change everything. But you could put a little caveat at the bottom, if you think, Mark, that.
Yeah,
Well, yeah,
that makes
the
sense.
first paragraph would be the place to put it.
You know what I mean?
The first paragraph, directly leads them, the New York State BLS protocol and New York State Collaborative ALS protocols specify the administration of oxygen based on oxygen saturation levels of the blood. So if you wanted to add something, we could add another sentence right there.
Yeah, to do with trauma and section, not to hold back on oxygenation. Sal, what do you want to
I
say?
just, again, when I saw, and maybe I could forward some of the paper, unfortunately, I got between Dr. Daly and Dr. Lombardo on this topic,
Yeah.
and that's a place you don't want to be. And
No,
I
it
mean,
was-
really, I mean, it was, it was back and, I mean,
Yeah.
both sides, throwing papers at each
imagine.
other.
Yeah.
And it was, it was just to watch it was interesting.
No, that's okay. All I was going to say, I think the impetus of putting out this advisory was strictly from they need to have a pulse oximeter perspective. It was never meant to be a training document. I think the protocols are, take care of that. One of the biggest problems we have with EMTs, going way back, you teach them that, there's a hypoxic drive out there, and they bring in Papa Smurf because they're afraid to give them oxygen, So I think the whole idea behind this was try to avoid this and tell them they need this tool to gauge oxygen. 92%, they should be giving oxygen. At 94 is really, there's what the question is, and that's, if you think it should be higher than that, then maybe we should put something in there. But if that's satisfactory for a TBI, then I think we're where we need to be. Just
Maybe from a QA perspective, Jeff, have you seen any data that shows that people are coming into the hospital that are below 94 without being on oxygen?
Not specifically, but I haven't scanned for it either.
We have numerous cases that are brought into us that we do re-education on, which is why I'm so and even though it's meant to be, essentially the goal of this document is to help introduce pulse oximetry to those agencies that don't, I never want to miss a training and education opportunity. So if we can pare down that paragraph and insert it, we see numerous cases of head injured patients that don't have supplemental O2.
That was Westchester's concern from the
And we don't
RTAC
pick
as
it
well.
up
That's
to
how
the
this whole
weekend.
thing got
We do
started.
it on a hospital basis, but it's very rampant in the community.
From RTAC, the regional numbers was 9% of patients with head trauma coming in with oxygen on.
Oh, with on.
Yeah.
With on.
So 80.
So 91% of patients are missed
It's not
in
so.
this protocol. And the underlying defense is they had a SAT of 94 or better. Conversely, cardiac patients who get oxygen administration when they're 94 or better, coming in at 100%.
Should we consider perhaps, Sal and I were just having a sidebar, sorry about that, because we both sit on training and ed. Maybe there's a way to put a training and ed document out that talks about this a little bit more so, and is maybe a little bit more encompassing than paring it down to a sentence on this to say you guys need to carry a pulse ox, and then follow it up, or even put it alongside with it and go out at the same time to say, here's some of the pros and cons, here's some issues, go see Dr. Daly with some paper, just some other data information to explain why it's more important to have a TBI oxygenated, even if it's above 94%.
I think it's a great idea to work on a training and ed document, but just so our document doesn't create any confusion, I think just inserting a small footnote, which is a pared down version of that paragraph, and removing the numbers, just so it's general guidance.
So I guess,
would be helpful.
so I don't disagree with anybody, I'm gonna play devil's advocate for 1 second, because I never do that.
Until we get to the SEMSCO.
That's true, too, I get that. What happens if it changes? And the collaborative protocols or those protocols change, and then our document says one thing, and it's different than
Then we
what
change
they
it.
are.
Yeah, we have to change it.
We meet every 2 months, 3 months.
All right, fair enough, that's fine.
And
So-
our EMS personnel will bring it to our attention if there's any discrepancy.
That's exactly
So,
right.
Except most EMS people aren't going to have this advisory without the protocol.
Right. I think that's my
That's why
point is
I
is
agree
not
with Mike
that
that we
disagree
stick
with
with
the
the
all, I agree with
protocols.
you 100%.
Yeah.
And if you want to start doing CMEs, we'd love to have you. But, because I think it's really a training issue. Like I said, the purpose of this was they need to carry this piece of equipment. And I think we're moving from a piece of equipment they need to carry to something that really needs to be covered from a training perspective.
Even if it's only going to the agency lead or the training director, and even ensuring that footnote prompts in their mind, okay, well, now I'm introducing the BLS pulse ox, I'm going to just remind people that for severe trauma, polytrauma patients or severely head injured patients, that actually supplemental oxygen can be helpful. So even if it's not getting out to the rank and file as an advisor from our group, their advantage is inserting just a small footnote because it gets the ball rolling. If we're 91% efficient in patients who should be having oxygen, we should be any avenue for advocating for oxygen in this patient cohort we should use and deploy, so.
Okay,
Take
so.
a motion?
Yeah, so I
Plus,
think.
can we attach the protocol right to the advisory when we send it out, to make sure that
Well, you can do that as
available?
in distribution.
Right.
Yeah, you can highlight that section.
Yeah.
That's great.
Yeah, just telling them to make sure they pay
Wouldn't make
attention
part
to
of
it.
this because then
No,
once they-
no, it's
even
a
if
separate,
we're
but just
changing,
that page
you could have
with
it.
oxygen administration where it explains how to use it.
Okay,
So,
Is there going to be a date when they need to have this on the ambulances?
we didn't put a date there, but it has to correlate with our protocol rollout. I thought we had,
This needs to be done by December 31st.
So we
Yeah.
can, yes, we can make it effective,
Okay.
probably effective 1/1 of 1.
And just so we understand the implications to agencies, like how many agencies would this potentially affect, and what would be the capital cost to those agencies that fire call
Those things are like $15 each.
$15,
Yeah.
yeah, like, I found 4 or 5 of them on that.
Yeah.
So that's, when we discussed it, we talked about that, and we felt that the product is available, you know, at a really reasonable cost, and that there was no reason not to make this a requirement.
Do you have an
That was a
idea,
discussion.
just generally speaking, what percentage of our BLS providers do not carry this at the moment?
Yeah, a lot. Because the problem is a lot of squads, as soon as they get their EMT, they give them this whole kit, and it includes oxygen. So,
Just do it, don't bother that.
But you will also find that most EMTs carry it in their personal cash anyways.
right.
I don't know
So-
numbers, though.
I make a motion that we send out the advisory with the addition of a sentence saying that, stipulating that in the trauma patient, that we should be aware of the potential need for oxygen administration despite saturations and clinical.
And I think it's a good idea to attach the protocol with it when we do the distribution, and then the effective date of 12/31, which is coordinates with the protocol update.
Well, yeah, so let's make 1/1/20. Okay, the training needs to be done by the 31st.
Yeah,
But, and then, so we will, Jeff, off the video, can we get what he said to put in here?
Yeah.
Okay.
And I'll finish it.
Okay.
All right, I will second that motion.
and all those in favor? Okay. Thank you.
So the next.
Hemorrhage control?
Is it worthwhile to put out a motion to approve the last month's minutes?
Yeah, I'll let him finish this thing and then we'll,
The next one is regarding the use of hemostatic dressings, compressive devices, and commercially manufactured tourniquets. The New York State Basic Life Support BLS protocols and the New York State Collaborative Advanced Life Support ALS protocols include the use of hemostatic dressings, compressive devices, commercially manufactured tourniquets, junctional tourniquets, wound closure devices, and other hemostatic devices which may be used in accordance with manufacturer instructions. The Hudson Valley REMAC supports the use of these devices and encourages agencies to procure, carry, and deploy these devices according to protocol and scope of practice. All such devices shall be approved by the agency medical director.
I have one small suggestion. So in the second paragraph, and encourages agencies to procure, carry, train with, and deploy these devices. Just as an EMS medical director, one of my biggest pet peeves is we buy new fancy equipment and then don't have the associated training with it. So just inserting and train with into that list of verbs.
I like that.
Yeah. Especially junctional devices. Okay, so junctional devices cost a lot of money. They're a minimum of $300, and they're all tricky to use and need training and practice. And it's like you even want to break. You need to sacrifice one just for your training use. So there's $300 flying out the door for people.
Hopefully if they're putting together contracts and stuff, they'll get a trainer from the manufacturer, but
Okay.
yeah, definitely.
Yeah. Point.
There's something else, you have to have a training nurse staff how to use too. It's not just the docs, but the nurses. we've had an agency or someone brought up with IT clamp, for example. Great, so we train the EMTs, but the nurses would never know how to get it off, they've never seen it before, and then you've got these bars on the end of it.
You want to describe what the IT clamp is for us, Dr. Mark?
It's basically just like a hair clip with needles with spikes in it, like Game of Thrones. You clamp it on, it brings the wounds together. When you take it off, you've got these spikes on the end of it, on a hair clip, and you sit there and you crush whatever you have. So, the biggest problem is that you're going to actually have to train the ER staff, and it's going to have the nurses, as well as the techs and the doctors, on playing with some of these potentially dangerous devices.
We have some interesting literature coming out on the IT clamp. It was initially developed for lower extremity junctional hemorrhages, like, that affected the femoral vessels, but was not amenable to tourniquet deployment. And the data has been, underwhelming. But what we find is for head and especially neck trauma, the IT clamp is phenomenal.
That's great, but the nurses and the doctors take them off are going to get hair clipped with these Game of Thrones. I don't disagree with it, but if you put this out, we really need to...
A tangential note.
I want to see a picture of that.
Having the...
You see that? I think it's
further training into our arena.
Agreed. I think that we move forward with many things, and I think that we have to just make sure that we bring this information back. And most of the physicians in this room are a director of an ED, and so that we have to make sure that we disseminate that information and as part of our responsibility to make sure our staff are trained and capable of handling these things that we're pushing out there from a pre-hospital perspective. We need to make sure we're all on the same page.
Well, we don't have mask pain, so we don't have to worry about cutting those anymore,
So do you want to make a motion with the addition of that one part on the hemorrhage control with training?
And what is that part?
And training.
Well, I just
Adding the words
prevent
and training.
having to come back here again.
Yeah, he just said,
training.
comma, and training.
Oh, well, with that addition, yes.
Yeah,
Yes,
yeah.
that is in here, yes, training
Okay.
with, yes, absolutely.
Want to make a motion?
Make a motion to send out this advisory with the addition of comma and training added.
One second that motion.
All those in favor? Thank you.
And that is all I have.
Okay. So service upgrades, there's none. Evaluation subcommittee report. Dr.
So,
Ashard?
Yes, we have 2 cases to review. One of us comes to us, it's a motorcyclist, middle-aged, versus a SUV. And it's a polytrauma case where there were 2 initial BLS agencies that were called for, and then additionally there was a request for an additional unit for transport. Upon arrival, and this case of note was brought to us by the
Brought to us by the QA officer of the agency that responded.
And when we initially reviewed the PCR, we only had the PCR of the transporting provider, where they did a very comprehensive trauma primary and secondary survey. Of concern, the motorcycle helmet had not been removed. The patient did have a depressed GCS. The leathers or motorcycle jacket had not been removed, and they found bilateral arm fractures. The patient also had a femur fracture. A traction splint had been applied prior to that provider's arrival. And when they were examining the traction splint, they found that there was no traction, in fact, being applied. So there was concern that the device was deployed without the appropriate knowledge on how exactly to do it. There was concern that the full trauma survey had not been done. There was concern that the helmet and as well as the motorcycle leathers hadn't been removed, and there were underlying injuries which had not been discovered. So it was brought to us by the QA director of this particular agency, and it was their intent to try and initially handle this in-house, but for some reason they said, oh, we thought maybe we just refer it to the region. So we're like, okay, why exactly are they referring to us? So we circled back and said, well, what did you guys find? And they said, you know what, the initial EMTs that responded are not particularly forthcoming in exactly, their response during this particular call, which was unusual. So I think our next step is to, as a region, Jeff and I will call that crew in just to discuss the case with them and review some of their thoughts and medical decision making and determine whether they're aware of how to pursue a trauma primary and secondary survey, and then maybe if we can get a traction one too, we'll see if they have the skill to actually employ one, deploy one. In general, with the evaluation subcommittee, we find that some people are very open to constructive criticism and say, okay, I can do better, thank you so much for that feedback. And other people are not particularly forthcoming, I did everything correct, please don't tell me what to do. So, our response is always, depending on where our providers fall on that spectrum, is in response to that. So I think the next step in regards to this particular case is just to bring everything through and have a conversation with them and see what their thoughts are. Sound reasonable, everybody? Next case, we're going to distribute a 12-lead EKG for you guys. So just to get started on the case, it's a 50-something-year-old woman with a history of MI, 3 previous cardiac stents that called 911 for testing. And overall, when I reviewed the PCR, it seemed like numerous ALS interventions were attempted, including aspirin, 3 sublingual nitroglycerin tablets, and even a dose of morphine IV. They did apply supplemental oxygen, which is interesting given the conversations from this morning. And they performed a 12-lead EKG. So we're passing around the 12-lead EKG. It went to, the case went to Catskills Regional Hospital, and they felt that it was a STEMI, and then very quickly transferred to Orange Regional Medical Center, where the patient had a primary PCI and had a definitive lesion, which was stented. So the documentation of the ALS provider for this EKG is normal sinus rhythm. Just wanted to see what the committee's thoughts are.
It's not incorrect.
Say it again?
It is a sinus rhythm.
It is a normal sinus rhythm. That is true.
It's pretty solid.
V2.
Yeah, so we're looking at V1, V2. And the question,
So did you purposely blank out the interpretation?
no,
And the
in
lines.
fact,
Oh, prohibits, I see,
this
I'm
is the
sorry, I
actual
didn't even read it
EKG.
right,
This is
sorry.
the actual EKG interpretation. Data quality prohibits interpretation.
Yeah, okay. Sorry.
So are you guys activating the cath lab on this, or?
I don't know.
We don't see it. We haven't seen it.
Oh, yeah, let's see. We can
Yeah, we're activating, but our cardiologists are blowing us off. Oh.
Yes. That's actually, I think.
Don't have our stenographer.
So was it transmitted?
Jeff?
No.
Not transmitted, no. They just interpreted it with normal sinus rhythm.
Can you pass the receipts, transmissions?
Yes.
All right, our EMS paramedic colleagues here, thoughts? Bypass local facility, go to PCI, or side clear? This is our opinion. There's no right answer, so that's what.
This is a patient rushing the room.
I would go to STEMI, but I might call medical control to go to PCS. If the patient looks like he's having stuff.
But that, especially with a history.
Yeah.
The history is pretty clear in this case.
Or serial 12 leads?
So the question is, were sterile 12 leads performed? The answer is no.
Yeah, I mean, this is, I don't know how far their transport time, but this is one of those things.
So
You
the-
really would want to do that.
That's a very relevant point, Dr. Larson. It would have been an additional 20 minutes to go directly to the PCI center. And an overall 50-minute transport.
52 minutes door to door.
Overall 52 minutes door to door, an extra 20 minutes to go to the closest PCI center, which is Orange Regional.
Yeah. Well, it definitely merited a repeat.
So I think this is an edge case, and we're all kind of saying, well, this is not a slam dunk. That's the tone or tenor of in getting the gathering from the room. So I think since we're already bringing in a crew to have a conversation with them, it probably behooves us just to bring in this crew to have a conversation with them. I think overall, reading their PCR, the ALS care was actually very solid. I think this is a subtle EKG. There are some learning points here which have been brought up. One is doing serial EKGs, and number two is just considering the patient's overall history. Strongly consider transmitting the EKG to med control and then potentially bypassing to go to a PCI center. Correctly.
So they went to the local hospital, and then did the local hospital transfer them out?
The local hospital called it a STEMI, transferred them out.
Did the local, I'm sorry, did the local hospital repeat the EKG?
They did repeat the EKG, I don't have that.
Local hospital repeated the EKG
Yeah.
and called the transporting agency within 8 minutes of the patient's arrival.
Yeah, so maybe that repeat EKG was dramatic.
Right, how much it changed?
Yeah, I mean, that's what you don't know.
There wasn't much difference, but it was more blatant in the repeat EKG.
So I think the learning point there is a very good one, is that dynamic EKGs, especially in a patient with a very strong cardiac history, and you already have a long transport and you have the patient connected to your monitor, so it shouldn't be overwhelmingly difficult to perform serial EKGs here. So I think that's going to be the learning point of this case and conversation with the crew. And again, our overall response is, no, you're wrong, don't tell me what to do. We would consider restricting their ALS privileges until they had appropriate remediation, but I strongly suspect that this crew, given how good their ALS care was on the PCR, will say, thank you for that feedback, serial EKGs are important, and I'll consider discussing with med control and bypassing the PCI center.
Question in the corner.
Oh, if you're using a LifePak 15 and it's attached to the patient, if there's a change in the 12 lead, it'll print that over.
Yeah, it should just come.
So they may not have printed it, and there may not have been a change.
Can't say I know what the,
I don't know.
which monitor.
And I don't know if they kept the leads on.
Was there any interpretation at all regarding the 12 lead itself? I know that maybe there was this thing for, you know, the 3 lead that they were looking at for the actual 12 lead specific. Was there any drop-down menu? Was there any additional things, STEMI criteria that was alerted, anything like that?
Their documentation of 12 lead EKG shows no
Gotcha.
So this is probably going to end up coming up down the road more and more, where the right clinical thing to do may not match the right operational thing to do for agencies. And so, not to say that they did the wrong thing or the right thing in this case, we may just see more of these cases where one crew can't go another 20 minutes out because now there's nobody in their area, and going to the local hospital is what their agency told them to do in this case, because they're going to get some care versus now no one has care for an extra 2 hours.
That may be a fair point, but just, you know, in like, take a trauma patient, for example, you can't bring a polytrauma patient to a non-trauma hospital. Why? Because we know they're going to have poor outcomes.
I'm with you,
So,
100%.
we have to advocate for the patients of the region.
I completely agree.
But I appreciate there are significant logistical challenges, staffing
Yeah.
challenges. What's it called when they do drop calls?
Right.
Especially on nights and weekends. Operationally, we have a whole host of issues in the counties that we cover.
Absolutely. Yeah.
And it's definitely going to come up in stroke even more, I mean, I think, because here you have a semi-objective tool, the EKG, you know.
That's right.
I agree with everyone, that this is, an SPPG is something where it doesn't fall under standing protocol, but it's one of those, I don't like this, let me just call med control, send it in, and say, look, this doesn't look right to me, and then with that discussion about control, whether you have a sort of EKG or not, and they say, you know what, you need to go to the PCI center. So this is something where it's not within the protocols, but it's something maybe from a training standpoint, you go, okay, Cruz, as in the criteria, but it just doesn't look right, send those off and discuss. And then you may find out, hey, we'll take the heat, of saying, hey, move on or don't move on.
And I think that's why we do CQI. It's like if we can bring the Q crew in and have a conversation with them, I'm fairly confident they would be amenable to our feedback.
I know a lot of crews really want to hear the part right in between where we're calling at a much lower level than they can. But it's the aha, and then alert us. So maybe this is really a training portion to tell to the region, hey, on that little bit, make the phone call.
I think when Ryan Greenberg visited us several months ago, he also made fact or brought up that, you know, hospitals are going to have an increased responsibility of actually getting feedback to the crews on the ultimate diagnoses. And that's something that's not happening regularly now, but I think many people are moving towards establishing those programs. And I think that's ultimately going to really benefit all the providers. Because, our providers are interested in learning and getting feedback on their patients and figuring out what the ultimate diagnoses were. So this is one of those cases, I think, when we bring the crew and have a conversation with them, they'll be pretty grateful that we have that conversation.
I think our missed opportunity in this case, when you bring just the crew in, is all of the other providers in the region.
Yeah.
So, and I often find that when I'm trying to take notes here on cases that come here, is that our learning opportunity, our teaching opportunity is in these cases, and I would like to see that the region then pushes these cases out in the form of an educational tool. Whether you do a PowerPoint that you push out that the agency heads can then do, or through this new mail system that we have, send it out to all of the providers in a bulletin so that it's a learning opportunity. And that may be also, so we as a region don't do much other than the stuff that's done by the training committee, and those folks already have full plates because we don't have that training position that we used to have here. And that would be a great training tool, and maybe again opportunities to talk about your trauma and your oxygen as well. So maybe the two groups can get together to figure out how we can push this information out from the regional perspective.
Well, the other thing is also, when we do call audits, and you get something, a sort of teaching case that's, area-wide or the whole kind of system is, hey, let's include this in the call audit. This is a special one.
That's right.
Doesn't necessarily come from your region, but we thought it was a great learning case. It should be part of this call audit. And just
This is an example
easy
of
list.
locally on a QA or a call audit CME that we would do at Vassar. These are exactly the types of edge cases that we discuss and cover.
Right.
Because it's a nuanced care and sort of your medical decisions that really
It might be nice, though, to have a platform in that fashion from the office that we utilize all the work you've already done and push it out there with an educational caveat. And just, this is what we learned, because, right, all these things should be educational, not punitive. And I think that,
Let's turn this into a...
yeah, and we could maybe do it in a platform from the regional office as, pushing it out there for everybody to review.
So perhaps after we review with the crew, and if they're open to it, we'll just put together a few slides and it's very easy learning points there, and we can just publish it to our Facebook group and things like that, de-identify and say call.
Well, even push it out to the agency heads, because I think that would be the best. But you would need to include, a lot of the key points here so that people understand that you need to keep up on traction. You need to know how to put traction slows down. You need to know that, if you don't got good interpretation, you need to maybe let's put the leads back on. Let's try the non-moving vehicle. Let's, here are these thought processes that need to go into this, and all of our providers should have an opportunity to learn from these events.
I think that's a great one.
Yeah.
How would they really, how could we get CV credits for it as well? Because that would really make it worthwhile for the crew. They want CV credits.
That's easy. It really is hard, right? We have 1 million CRCs. Anyone can underwrite, right? Anyone can underwrite any of the, whatever you put together.
So then how do we do it if we did a webcast from our site?
So what we have done in the past, I'll just speak with regards to the last protocol rollout in 17. This committee said that if you sit down with your folks and you do the protocol rollout, this presentation, you get 3 hours of medical control contact hour. So that this group can just say, if you do these 3 cases in this format, you can award 1 hour medical control contact under our authority.
That sounds like something we can work on, Jeff, right?
Absolutely. That's great. So people can log onto our website and just get the credits, do it, prove that they did it, and bring it back to their agency. That'd be fantastic.
Maybe they should see a podcast.
So one of the things, with this, and we'll see how it works out with the ALS collaborative rollout, but it's a very similar LMS. They can take questions as they go along. They take a test at the end, and you know that they've done it. So, and we can get in on that system.
Yeah, as of January, we should be
Yeah,
able
we should be able to get in on
to
that
be able to use the platform that the BLS protocol came out on.
And sorry, I missed the last meeting. So we're going to use a LMS from Rochester, from the state? Because there were issues with using the LMS from the state, correct?
It's a separate system than the state's, but it's the same mothership.
Is it University of Rochester?
I don't know whose it is. I don't know the technical aspect behind it, but it's the same login. So it's the same same Archie program.
Both entities are using the same program to roll out this thing, so when you log in tomorrow.
Just when, because, you know, we developed all those training videos, we're working with the University of Rochester, who has an identical LMS in New York State. So everything that and they have everything loaded up and queued, and so I suspect it's probably University of Rochester.
I'm pretty sure it is.
Okay.
Yeah.
We may have to change and/or update our medical control component of our policies and procedures, because at the moment, all medical control is supposed to be back and forth, interactive, and not just being able to watch something. So these were special cases for rollouts that we did this, so maybe we just have to identify that separately in our document to make sure that we're covered to be able to do it.
Mm-hmm. And that can be specifically from, you know, evaluation subcommittee where we get these real cases going forward to use as an educational benefit.
Right.
All right, thanks, Dr. Rashad. That's it. Enforcement notifications, there's none. Helicopter committee report, Dr. Larson.
The helicopter committee has not met, but we really want to meet. So what we are, you know, and the helicopter committee has not met for a long, long time. It's kind of, you know, technically fallen apart. We're going to bring it back together, and it is going to be open to anyone who wants to participate. And we are going to put out a date sometime. We'd like to meet before the end of the year. So we're going to try to put out a date either in late November or maybe December sometime. So if we can just put it, we'll put it out on the Westchester, and we'll put it out on the Hudson Valley information site, and hopefully we'll get some attendance and get some input, because we really haven't talked about air assets in relation to all of us, and where we're at in it. So I think it'd be good. So that's our plan.
All right, thank you. RTAC, I don't know why it's under you, Michael.
I don't either, and actually I did not attend the last meeting. I think there was one not long ago, right?
Yes,
Yeah. There was one at Westchester Medical Center in September.
Yeah, and I mean, it was kind of the usual thing. We reviewed some cases. We talked a little bit about a head trauma patient. The other thing we did talk about is a plan for MCI and how incorporating the regional trauma centers into that MCI plan. And basically the resolution kind of on that is we need to work with the MACE team, the Mutual Aid Coordination Entity,
I've
which
reached out
is...
to them a couple times for presentations, and they never gotten back to me.
Who did? I thought you did one. Didn't you do one?
Not today, I did one here.
Yeah, okay, so they never has had an official, okay. Yeah, I thought we had done one, but, okay, so, anyway, we'll get that on the agenda. But anyway, sort of working through the MACE team to try to, because they were like talking about creating from scratch, some kind of trauma MCI team, and it's like, well, you've already got this entity that can coordinate all this kind of stuff. Whether you're talking about, sending aid to another hospital in the form of whatever, physical equipment, or actually sending trauma surgeons and OR nurses and that kind of stuff to another hospital because they've been overwhelmed, or diverting, how you would divert patients or take patients from an overwhelmed hospital to various trauma centers. So, that's the kind of thing that we're trying to work out. So I think, first order of business is we'll get that on to the RTAC, because I thought for some reason we had given them one.
Yeah, the MACE team wasn't presented here.
Yeah.
I think it's a 31 hospital, Rick already signed off on it, right?
Most people may not know.
It was brought up that not to repeat the efforts of the MACE. This was more of a physician replacement program that was being presented to go to a small community hospital that has an MCI for a 48-hour pack. And the doctors would go in for 24-hour shifts and then be replaced by the next crew coming from one facility or another. And that in conjunction with what Mace could offer to the program as far as equipment or equipment cash that was available through the state or the feds. It was discussed amongst that, and they did talk about bringing, for a presentation to come in, but I can follow up.
With the Mace, it's already in there about sharing personnel, and maybe we have to specify trauma surgeons, stuff that's something we can work on.
I mean, there's certainly that whole credentialing aspect, and the other thing is, I mean, I don't know, the doctor who presented it, I think said that there are some models out there, but to me, I'm not sure about bringing outside surgeons into, into how well that would work practically to bring outside surgeons into, another ER. I think you're probably going to land up more likely transferring trauma patients out, and we just have to figure out how to make that a smooth thing, and also just making sure that hopefully in a MCI system like this, that serious trauma patients would go to the level 1s and level 2s, and less serious trauma patients would get distributed out to community hospitals, as they should, to not overload the trauma centers. But anyway, to be discussed, and I think to work through the MACE team is probably the best entity to coordinate something like this. And if they really want to push this thing about credentialing in other hospitals, God bless them. But I will play some role in that, but I don't think it's going to happen.
So Rich, you can help fill in the gaps for me, but there's a large region-wide exercise on February 26th put on by the Department of Health, a coalition surge test exercise.
Yep.
Where there's going to be a severe winter storm that's going to shut down several hospitals. There's going to be plans for evacuation, intra-agency hospital training. So it's quite an event that's, the MACE team is going to be part of on February 26th. Do you want to help educate people about that?
Well, it's a state requirement. The hospitals are required to participate, and they had a exercise planning session, and my co-chair volunteered to actually evacuate patients out of White Plains, Ed, and contacted me if I wanted to be involved with the Kingston Ed. Apparently some folks are reluctant to actually move patients, but I think we have to start looking at moving patients and looking at those resources. Because one of the things that when we do this is EMS. Where is EMS in this? And the sad part about it, EMS doesn't get a taste of the grant money. And I don't know how we fix that. The hospital gets $12,000 for participating in this, but EMS doesn't. But if we're evacuating hospitals, EMS has got to be involved.
I'll just read out a couple of the details so people are aware. And we found out about it and hadn't participated in the past, and we're going to be, as our EMS committee ambassador, we're going to be stepping up and adding more exercises on the tail end for our ED folks. But severe winter storm, potential evacuating hospitals are White Plains, Nyack is tentative, and Kingston is tentative. Additional facilities to evacuate: Elizabeth Seton Pediatric Nursing Home tentative, Blithedale Children's Home tentative, and Sunshine Children's Home tentative. And then overreaching objectives for the hospital are activation and review of 96-hour plans, real-time list of patients that can be rapidly discharged, patients that will need durable medical equipment like urgent dialysis, and then staffing, category redeployment, and evacuating hospitals to assist at receiving facilities. So a pretty big exercise.
Yeah. As you mentioned, in the nursing homes, we're getting a lot of requests from them for something along the MACE line, because they're now under CMS, have to follow basically the same thing hospitals have to do with their emergency management plan, getting them involved.
So Bill, has the region been advised of this?
Haven't heard.
So in your conference project, it's probably appropriate that you bump that up to the state level and say that this is a significant exercise that is occurring without the involvement of the EMS, and certainly we need to be a part of those plans.
The last exercise that we had representatives from DOH on site at the hospital that were there, and it's a tabletop exercise. It's not a physical exercise. This next exercise White Plains would be evacuating patients. And one of the things that we identified from the last drill that we had was the fact that we couldn't get enough ambulances to be able to evacuate effectively the whole hospital. So we basically were working with 10 ALS ambulances and 6 BLS ambulances to evacuate 345 people. And
Storm will be over.
It's
gonna be spring.
It takes 3 hours to do a turn to Albany. You're not gonna evacuate highly critical patients in a quick mode. And that was one of the learning lessons that came out of the last thing.
And every hospital, and my evacuation plan is, they go through, like Dr. mentioned, that you identify the patients and who can go home, who can go to a nursing home, who can go on a bus, an ambulette, and you save your BLS, ALS ambulances for the ones that are more critical. But that's all part of your evacuation plan, and they should have that, is where they're going, and that's part of your EM plan.
Yeah, I mean, there's the problems of the bad storm and stuff like that, but it's amazing how fast you can find patients to go home. In an 800-bed hospital in Las Vegas, they got 161 people discharged that night when the Vegas thing went down. So, that's a significant number of people that you're pushing out the door and making room for incoming. Actually, I think we're hoping maybe that a winter storm will hit during the exercise, so then we won't have to do it. I was just kind of surprised that was when they were scheduling it. But anyway, I think that there's also in our region, in the tri-state region, there are 21 of the mass transport buses that are sitting out there, and that kind of, that I think is one of the things that we're going to be looking at in terms of moving those patients. And, those can be, that system is actually fairly well intact, and those transport vehicles are out there being maintained by FDNY, being maintained by Yonkers Police, maintained in New Jersey, maintained in Connecticut. So those things I think could be pretty rapidly deployed. That maybe one mechanism, and they can take, I think, 12 to 15 basically bedded patients, and a lot more if they're sitting up. So. Anyway, it's definitely out there, this thing, so we should get a little bit more clarity on it and what our role is, and I absolutely agree with the EMS thing. That's always the thing that's left off.
All right, thank you.
When is the next RTAC and where?
I want to say January.
They hadn't picked it, I don't think. They hadn't picked it, and I don't think they had picked the hospital either.
So you'll bring it up on your call, though?
Yeah.
Okay. Quality improvement report, Jeff?
The progress on NEMSIS 3.4 continues. We are on track to have all of our agencies migrated to that platform on 31st of December. We have had a couple of issues with one vendor, and those problems are being identified and corrected. We had one issue with the state in setting up permissions. They checked the wrong region, and that prohibited data flow from one of our agencies. That has been corrected. ESO has 42 agencies, and I think that they maybe didn't plan this out well enough for the deployment in New York State, and that's the vendor that we're seeing some issues with. And it's mostly small stuff. And as the problems come up, they are fixing them fairly quickly. The big thing that we look at is an import failure, and that means that something in the schematron wasn't allowing that document to pass. And usually it's a mapping error within the vendor. We identify it, they fix it. It goes from our regional bridge to the state bridge. The state bridge will kick back a PCR that is validated at 97 or less. The average validation from our bridge to the state is at 98 and change. And part of that is because we scrub the data first. If there's a problem from the agency, we can identify that, kick that back to the agency, they fix it, resubmit it, and it passes. With NEMSIS 2, we usually had to wait a month to 6 weeks to see agency data, and some of it averaged 37. And that was a high month for some of these agencies. But there was no way for the vendors to reach back and fix some of this simply because it wasn't a state requirement. With the states being a little bit more robust to this rollout, we're seeing much better data all the way around. Beginning in January, I'm going to be setting up automated CQI reports for agencies. And I'm not really going to focus too much on the commercial agencies because their programs are pretty robust as it is. But I want to get more involvement with the BLS agency medical directors. And we're going to take a look at how agencies are performing with difficulty breathing cases, chest pains, seeing how the adherence to protocol is. And these reports can be set up to be automatically done and sent to the medical director on a weekly basis. So once I set the report up once, it's auto-generated from that point forward. So that's going to give us a lot more insight into agency performance across the board.
Okay, great. And thanks for all the hard work. Protocol committee, we pretty much did, Mike. And the collaborative protocol app we announced is out. CMAC and SEMSCO. CMAC, I did not attend SEMSCO, but I did attend CMAC. We pretty much focused on the protocols in New York City joining, in a sense, the collaborative effort, however, still maintaining separate protocols in certain areas. So it's really not, it looks the same as ours, the format is the same, they developed and took our format, but still maintaining a separate entity, which we're trying to see if we can have everybody be on the same page, which did not happen yet.
Unified versus collaborative.
Yeah. So it was pretty much, we went forward with looking at what they're bringing to the table, and it's still out there. More interesting was SEMSCO, and we're going to be able to put out a document that pretty much summarizes everything that happened in SEMSCO. David, if you want to just.
Yeah, the only other things that came up through both, and I'm going to turn this 7-page document into a half a page, hopefully real quick here. There's some Part 800 regulation changes that are going to be coming down the line. That includes everything from EMT certification going from 3 years to 4 years for EMTs and paramedics. Equipment requirements changing to be way more appropriate than they were 25 or 8 years ago. And some things like that. There's a new, I don't know if you all are familiar with the ET3 model that's being proposed by the paramedic Cave. And New York City has a pilot with that. They're allowing non-pilot ambulance providers to transport under the model as well. What this allows pre-hospital providers to do, why it may be really important to this committee or to this group, is to transport to a non-hospital facility for certain cases. And so I don't know how that's going to look for what we do or how we do it, but it's another thing that's out there that we should at least be aware of and be able to have some input in. The CME program is one of the ways that paramedics and EMTs recertify. The state has a new one that's rolling out as of January 1st, 2020. The number of hours required to recertify is down in both categories. For EMTs and paramedics, it used to be 72 hours. Now for EMTs, it'll be 40, and for paramedics, it'll be 60. So that's gone down. Some of the categories have changed a little bit as well, and they have some mandatory pieces that they want people to look at. a huge discussion about pediatric transport policies and capabilities. They're finding that really we are not transporting pediatric patients well. Even if now we're finally getting them to the right place, we're just not doing it the right way. So there's a lot of education going out about that. Excuse me, there's a QA/QI committee as a part of medical standards looking into some metrics and updating the QA/QI manual that hasn't been updated in quite a number of years. I think it was 12 years old or something like that. Some of these metrics that they are looking at now for sure are chest pain being placed on 12 lead within 10 minutes, cardiac arrest with ROSC, Narcan use and the patient refusing transport, trauma patients going to trauma center based on CDC guidelines, a stroke TIA patient that has a blood glucose check, and a stroke TIA patient that is transported to a stroke center. These are some basic ones that they're looking at. They're going to expand it outwards from there. There is from finance, they're doing a cost per training survey to go out across the state trying to increase reimbursement. This was very interesting. In 2000, there's one of these studies was done in 2000, and then one in 2008. In 2008, New York State reimbursed 71% of course costs. With the CPI showing a 19% increase since 2008, that means that today the state is reimbursing only 51% of actual course costs for EMS agencies. So that sort of helps in understanding part of the reason why we really have a shortage of personnel and training and that sort of thing. And I think that covers everything that we had. Collaborative protocol changes they were looking at. Don't treat fever in patients less than 60 days old. Ibuprofen can be used only in patients greater than 6 months old. It's contraindicated in pregnancy. Heat emergency protocol to allow cooling before transport. And Tylenol dosing change depending on how it's carried by the agency. I guess there's a couple of ways that it could be possibly carried. So they're just making sure that the protocol covers those ways.
And we'll submit out a overall document that has,
That's correct.
some of the information on there so everybody can review.
So it's important to note also that there is a revision to the collaborative protocol that has been previously released. And last I knew, that link was not available on the state's website either. So just, there is a new version based on what Dave just discussed.
Okay, open forum. I'll recognize the Township of Greenville, volunteer and begin the score.
Hi, my name is Tyler Van Buren. I'm the second lieutenant with Greenville. I'm an EMT for 5 years, combat medic for 5 years as well, which is guard, CPR instructor, and a staff agreement instructor. Greenville got heard some agencies possibly doing iGels for the BLS agencies. We talked to Dr. Merck about it, our captain did, and we were looking to start a pilot program out on the western side of Orange County, where sometimes ALS, and when they're available, they're still coming from 20, 25 minutes away, if they're available. And then we have Port Jervis that borders us, very rare for them to get any type of ALS. And they have transport time to Vancouver, maybe 5 minutes into the city, but they can be upwards of half an hour if they're out on the outer sides of the district, or if they're out in Pennsylvania. A little bit about Greenville is we're a slower agency. We do about 450 calls a year. Of those 450 calls, ALS isn't available about 6% of the time.
How much?
6%. That averages out to us about every other week they're not available. Sometimes we get a secondary ALS agency from Walkhill, and they're coming from 25 to 30 minutes away to intersect with us, if we even go to Warren Regional. My captain wrote up a policy on how we're going to implement the training. We're going to have Ryder, maybe Dr. Allen or Dr. May to talk to. They're going to come out, do a anatomy and physiology class on airway, how these iGels are inserted properly, contraindications, when they're indicated. We're looking at it because it'll better improve patient outcomes. We can secure it faster and reduce the chances of aspirations with patients. that's really all that I have. I mean, the providers, the doctors, sorry, you know, those are called doctor providers. So for the doctors, we do have a copy of our SOGs that we can pass out to you guys to review, and I know Dr. Murphy has reviewed these and is okay with us.
The one thing we were talking about, Tyler, just when we did the pilot project with CPAP, we did have to apply to the state and send in both the document, what the protocol would be, the educational, the follow-up, and that's something we'll have to do, provided people are comfortable with a pilot project in the area. I've brought up a couple times to the protocol committee that we have to start expanding some of our reach with you know, EMTs and at both the basic and EMT advanced level, as people have brought forward to us utilizing that tiered response. So it's something that is on the forefront. We've talked about it many times, and we have to really look at expanding the reaches of what we have to deliver in the region. So this is one of those projects that Greenville wanted to bring forward and apply for a pilot project to utilize in the region, in their region, Greenville.
Now, pilot projects are projects that are the state sponsors or accepts for enhancing the skill at a level. So right now, these airways are not in the scope of practice of BLS providers. So they're well monitored, there's a fair amount of participation that we need. So there's a lot of rules that we have to follow since it is out of the scope of their normal practice. So we need to work on getting all that paperwork together, making sure that we have everything that we need and we have enough people that are going to be doing this to make sure that the pilot's valid throughout. And then once it's accepted that the skill is doable at that level and is successful at that level, then it can be spread out throughout the entire state once it's signed off by the commissioner. And then what happens is the level of the EMT throughout the state is then raised.
I think it's exciting that BLS agencies are interested in placing supraglottic airways. Honestly, it's not a challenging skill, and I think for motivated BLS providers with good foundation can definitely lead to improved patient outcomes. There are numerous other states that are moving in this direction, and there are a couple that have already approved BLS statewide supraglottic airway protocols. So I think a pilot is a great way to approach this, and I want to just applaud you for your efforts. At the BLS level, though, just as a point of clarification, even though it's an advanced airway, we would not be using an end-tidal CO2 continuous capnography.
As it turns out, Greenville's actually also in the process of, we got a grant from Senator Metzger. We're going to possibly look to purchase LifePack 15 so we can do an inline end-tidal CO2 on the cardiac monitor with us. Or the iGels, they do come with a colorimetric meter. It's all describing our policy depending on which way we go.
That'd be great if the physicians are coming to your anatomy and physiology. You can add a lecture or two on end-tidal CO2 monitor.
So, Dr.
Yeah, the iGel has a little portable, you know, the colorimetric device. Yeah.
And then it sounds like there may be other additional BLS agencies in our region that are interested in participating. So in regards to a pilot, would it be one agency or could even multiple agencies band together?
We can have multiple agencies. In fact, it's probably better because I think we'll have more volume that way.
Yeah.
And that way you get statistically significant data and we can really see what's going on. So that was what Bill's point was, is that we need to make sure, once we go through this process, is, you know, get other agencies to jump on the bandwagon so that we can have more of it out there and more numbers.
And maybe as we're seeing more residents in emergency medicine in the region, perhaps some interested residents may be interested in working with you guys to do active academic research as well. So.
We have one here this morning.
Yes.
That was nice.
Okay, thank you.
So they're submitting their paperwork to the region, and is there a
And we have to pull the stuff for the state, because we didn't pull it yet. We have to pull it and apply through it as a pilot project that way. So we still have some homework to do, but they've come through with their educational process, their way that they want to roll it out, and he's going to, Mr. Van Buren's going to, solidify the educational problem, whether it be with Dr. May or Dr. Ashad, or there was somebody else they had too.
So Dr. Allen, he's at a
Allen.
point where he used to be an anesthesiologist.
Yeah.
I'm very familiar with doing airway classes.
We all know Dr. Allen. Okay, anything else? Dennis?
Just a question for everyone. What is everyone's opinion about our crews taking pictures with a non-HIPAA phone?
We're not supposed to be.
But we are moving with Epic to
Yeah.
being able to take pictures in a HIPAA-compliant fashion. But up till now, we've been using
So it's not a problem until it's a problem.
I was just about to say exactly that.
Yeah, triage.
And then triage is, of course, one of our HIPAA compliant needs to transmit photos.
Non-HIPAA compliant phones.
Right, right. Goes on
Crews
all
are
the time.
taking pictures on scene, they're taking pictures on standby, they're taking pictures on like an MCI event and broadcasting it live, which is a tactics problem.
So is there a HIPAA compliant phone or is it really the app?
I believe it's the app.
So triage operates above the libraries of the phone, that's what makes it HIPAA compliant. It's the same way that Pulsar works as well as another
cloud-based
agency.
I mean, it depends on, I know that Montpelier, they subscribe to Curator. I don't know if that can be extended to EMS, but various hospital systems have HIPAA compliant apps.
Triage is in the area, but crews are taking photos that are non-HIPAA compliant. It's gonna become a problem.
I mean, there are fire agencies that photograph scenes and patients.
But they're okay because they're not under HIPAA. They're fire PD, they can all do that, news agencies do that.
What is an agency
Every hour.
directive, it's in there, it has to be in their SOPs, if I'm not correct, that they cannot use photography equipment, anything like that.
Well, not only does he
And,
have
oh,
that-
and their social media posting compliance as well, because you see more and more of that.
I mean, not only does he have that within it, and a lot of people taking pictures, if you take a picture of undercover police officer and post it, that's a felony. And now you have an agency EMT posting a picture, and it becomes a felony for them? I mean, we're good.
Maybe we could put out a renewed interest in HIPAA policy and put
Well,
out,
do we even have a regional HIPAA policy?
And is it just HIPAA or is it HIPAA and social media?
Well, that's, I mean, so the question is it appropriate for the region to go there? Maybe that's another discussion for your executive director group.
ask them
because-
if anybody has done that.
No,
or-
right,
yeah.
because we shouldn't, I mean, it should be, if we're gonna do this, it should be across the state. I mean, this is a big issue, and certainly we should be looking at it as other regions should be looking at it as well. I concur.
I think that's a very logical approach, is to kick it up and have a director's meeting on it, because I think it's not an uncommon problem.
And for trauma surgeons telling the EMTs, take a picture, I want to see what it looks like. But we're not trained in kinematics off of a photograph.
Tell them to use one of the 3 commercial pre-hospital notification tools that are out there.
Yeah,
But
that works.
But that would work, but again, the crews have to understand what they have to use, what they can and cannot do. And we're taking off time from, patient care from getting a picture.
Is this a regional issue, or is it an agency issue? I mean, when you think about it from a hospital standpoint, there's no it's a hospital issue for the hospitals. It's a particular, or hospital system.
It's actually a worldwide issue. I mean, it really is. I
Whose
mean, look,
responsibility
I'm
is it,
still
though?
getting, the orthopedist, well, I'm out to dinner with my family, could you just send that over, just send it to my phone, just send me a picture of that fracture, I want to see that elbow before I break from my fabulous dinner here.
But the other thing is, if this didn't happen, we wouldn't have such great training pictures to utilize, of the Boston bombing.
Right.
Yeah, but the ultimate question is the transmission of that photo, right? So
Right, that's where it
If you
becomes.
take a photo, your entire phone is now discoverable. Everything in your phone is completely discoverable. Every bit of email, everything you loaded and logged in, and also what appears for the public. Why are you texting your spouse? I'm sick, you're texting somebody, and they're taking time taking photos, and they're on standbys releasing tactical information. And we're HIPAA, I mean, we're news agency, not a problem. Want to be fire department? Go take a look because you want, but we're still governed by HIPAA, and they too are governed by HIPAA.
So if you have, I think the information you have is valuable. If you have specifics, I think maybe if you could just sidebar with Bill so that as he pushes it up to the executive directors, they understand what the magnitude of those specific examples are great, and I think you should pass them along with them.
Just look on social media and look on YouTube, you know, any EMT that's taking photos and posting it, you just violate HIPAA. And you could go after them, which is not what we want to do.
Under other new business.
Again,
The 5-minute cap.
It's the actual
Sure.
posting that's the issue. It's not that it's on their phone, because they walk around with information all the time in their head. They're not going to verbalize what they see. The responsible EMS provider should be deleting the image, and of course not uploading it. But once they upload it, that's when they violate the HIPAA policy. And once they've used an app or like a text messaging to send it to you, that's when they violate HIPAA. It's the transmission. So it needs to be done on the secure app, and then obviously the photo should be deleted. So that's where the policy should extend to, you know, social media practices and
I don't know about that particular point, but if you took it but never used it, then you're okay. But then once they show somebody else,
It's
then they're
transmitted.
HIPAA non-compliant.
Yeah, that's what he means by
You're right.
transmitting
So if
the
somebody
data.
takes a photo on scene and then shows you their phone, I don't see that as a HIPAA violation, because it's not an inappropriate transmission, it's a need-to-know provision of information.
But you're not part of the treatment team, so therefore you just showed someone the HIPAA.
No, I'm talking about.
He's saying when you are.
If you are part of the team.
If you're part of the team.
Yeah.
But if you're not part of the team,
Well, that's different.
then you violate HIPAA.
If you're sharing the information.
Yeah.
Yeah.
Without even transmitting, just say, hey, look what I saw yesterday.
Yeah,
Yes,
that should
because
not
that is
be-
transmission.
Right.
That's transmission.
So, yeah, that's an individual responsibility. I mean, so like if I take a picture of an X-ray in the ED and I need to send it to to Westchester or whatever, I can't use my cell phone. It has to be sent responsibly through the appropriate app.
Correct, although the other person, you just assume you got that person, and that person is part of the treatment team. So that's a little bit the problem. The transmission, you can't guarantee the security, but you're not violating the HIPAA. Because that person, let's say, is orthopedic or bone injury, that person's already declared part of the team.
So certainly also of interest is, it's just a vehicle. If there's just a vehicle with nobody in it, is that a part of HIPAA?
Absolutely. It's definable. Whether you have a Koenig SSR or whatever it is, a one vehicle and it's owned by one person, that's identifiable, that's not. Yeah.
So that's important that we include that as part of this.
I think there's some local paramedic JDs, paramedic lawyers. I know several in New Jersey that will lecture on this topic occasionally, so maybe worthwhile just to get some more insight into best practice.
You know, there used to be a document out, and I thought about this not long ago, a EMS law summary document that we used to get in the mail occasionally. Does anybody ever still see those or those publications? Because EMS law is something that I don't think we spend enough time on, and it would be great to see these cases.
I think it was part of EMS Insider. It was put out by the Page Group. Correct. Yeah.
Okay.
Right.
Okay, and you had one more thing, one last thing.
I hate to open it at 11 o'clock, and perhaps we'll talk about this more offline, but flood, the update from CMAC, I was wondering, I didn't know any of the
They
details.
still haven't
but-
pushed out anything more. They have new people in charge of the committee who say that they're making it easier. We did have about, I don't know, there was quite a few more agencies that were designated as a blood transport agency. They did approve quite a few. We did not find that the process was any less laborious. We felt it was still quite laborious. But is a new, and I can't remember her name, the gal from the state who's responsible now for the blood transfusion policy, but,
From
they,
Wadsworth it was, right?
yeah, she's affiliated with that, but, they did approve quite a few more agencies now. I think 12 or 13, did they say, throughout the state?
Yeah, it's at least that.
It was some number that was up there.
But as far as process changes, it's still hard.
Yeah,
'cause-
it's still quite laborious.
Was there not a discussion, though, that regions can now enter into agreements so that not every hospital has to have an agreement with
Yeah.
every agency?
Yes, that was another thing brought up, because the way the original policy was, you had to have an agreement with every hospital you use, so you can imagine that is really quite cumbersome, exactly. So they are looking at some way to do it so that it can be more regional wide, and not that you have to do every single hospital that you have an affiliation with, but more your region for where you operate out of.
That's not implemented yet, though.
No, it's not implemented yet. They haven't gone through all of the kind of nuances to make it work, but that's what the thought process is.
So I guess we'll just wait and see. And
Yeah,
then
it
once
hasn't, it's a very
do
hot
something.
button topic at CMAC.
No blood pressure.
Yeah.
Now, there is some discussion about helicopters, though, right? Is that looking like that may happen for 2020?
It's getting closer and closer, but no definitive ruling yet. Because we, like you mentioned, hospital, we have over 200.
Yeah, like how can you possibly apply to all those, yeah. All right, anything else on the open forum?
January 6th is the first day of NAEMSP in San Diego. I don't know if it'll affect anybody else, but that'll be really fun.
So they also put out, so we have REMAC meeting dates, so that's one we can talk about, and whether do we need to revise it, go to the 13th, or...
We should have the meeting in San Diego.
Yes, I say, since it's January, let's have the meeting in San Diego. All right.
Do we have to approve the last set of meetings you mentioned?
Yes.
Yeah, so, Bora just left.
Parliamentary procedure.
Yes, we have to,
I heard Laura say yes.
he said
say
yes? Okay. All right, so it's approval for the minutes of the last meeting. All those in favor? And that's Bora's hand going up.
He's gonna get
Yeah, that's right. Anything else for open forum? Okay, thank you, everyone.